Distinguished chairpersons, respected delegates, a very warm good afternoon to all of you. And first and foremost, my sincere thanks to Dr. Randeep, Dr. Khilani, Anant Mohan, Karan, Vijay, and other members of the team for this wonderful opportunity. I have spent 35 years in this place. It's my professional mother, and coming back here is always one of the most pleasant experiences for me. So, organizers, thank you very much for giving me this opportunity. The title is to talk about prevention of recurrence of pneumothorax. Leave it to the surgeon. As expected, my answer is yes. And I'll give you the reasons why I say yes, and I say a very, very strong yes. And I have no doubt that by the end of the presentation, everybody, including Dr. Rajadhar, would be saying yes, yes, yes. But before I do that, I pay homage to this gentleman, Dr. Itard, who actually coined the term pneumothorax. He was a student of Lenick. And I also would like to acknowledge the support of two of my DNB thoracic surgery residents, Dr. Mohan and Dr. Navdeep, in preparing. Residents do literature search much better than we do, and I want to acknowledge that they have contributed to whatever I'll be quoting here. The topic we are discussing here is spontaneous pneumothorax. We are not talking about the other kinds of pneumothorax, and we are including both primary and secondary. What is the aim of treatment? You treat the index attack, you treat any underlying disease and prevent recurrence. And the methods available, as he has pointed out, range from observation, aspiration, catheter aspiration, ICD, chemical, medical fluorodesis, done through ICD or done through medical thoracoscopy. These are all medical methods, and you have surgery, which could be open or VAD surgery. So these are the various methods available. The factors which have been responsible, which have been related to recurrence include young age, so younger people have higher chance, male sex, low BMI, especially very tall individuals, smoking history, presence of bleps and bulli as seen on HRCT, and size of pneumothorax. There is this nice study where they reviewed the literature on patients with recurrent primary spontaneous pneumothorax to look at the incidence of bleps and bulli on HRCT. In the pediatric population, about 50%, and in the adult population, close to 75% of the patients had. So lung episodes show bleps during surgery and on CT scanning in up to 90% of these cases, and these bleps are thought to play a significant role in its occurrence. There could be porous areas elsewhere also, I don't doubt that, but these are the areas which are responsible for index episode of pneumothorax, and if you don't handle them, you are actually likely to have more recurrence. So residual or incompletely excised bleps are believed to be the reason for recurrence in majority. So the most important issue in pneumothorax is the rate of recurrence is the primary indicator of the success. When we do surgery, what do? We treat the underlying pathology to prevent recurrence and give a better quality of life. Conventionally, it has been done by thoracotomy, and now there are minimal invasive methods, which is VAD spolectomy, and even further additions like uniportal, where you just give a small single incision, or a needloscopic, where you use a 2 to 3 millimeter scope instead of the 5 or 10 millimeter, thereby reducing the size of the. I'll skip this video because he has shown the picture of the thing. Now, why are physicians and especially pulmonologists wary of surgery? There are 4 myths which I want to point out here. Number 1, that potential harm of surgery is not inconsiderable. That's one thing. You feel, all of you fear surgery. Risk of recurrence after first episode is not high enough to justify exposing the patient to such harm. So people quote that, no, this could be 10%, 20%, whereas in reality, as he himself has shown, it is about 50 to 70%. The so-called high cost of the procedure. But what is conveniently mixed up is the total cost which the patient entails. And non-surgical methods are as effective as surgery. These are the 4 myths that pulmonologist, if I may use this word. I know that 100% of the audience here belongs to that. I'm the odd man person here. But these are the 4 myths that you suffer. I'll address, so this is how you have these 4 myths here. And the reality. So this is what I'm going to bust these myths here today. And all of you are going to agree with me. For good ideas and true innovation, let's debate. So let's debate this. I'm not surprised that in his very elegant presentation, not even once he talked about other guidelines or went into actually the main operative parts of the guidelines. There are three main guidelines present here: chest, BTS, ERS. If you look at these guidelines, all of them, when they talk about prevention of recurrence, unambiguously say, in the vast majority of cases, the prevention of recurrent pneumothorax should be undertaken surgically using either open or VATS approach. Small number of patients, of course they do qualify, that small number of patients who are too frail or unwilling to surgery can have chemical. So my addition to that is that this decision of patient being unfit for or not willing should be taken by a surgeon. Time and again I see that physicians take a decision, oh, I thought this patient is too frail for surgery. So that decision should be left to surgeon. You look at ACCP guidelines, again, preferred method for prevention of pneumothorax is surgical because of the lower, mind the word, lower recurrence rate with these interventions compared to this clotting agent. So what are the objectives? We treat the respiratory dysfunction, we manage leak, and we prevent recurrence. Now let's look at these different methods. You have observation here, simple aspiration, catheter, ICD, chemical, and surgery. And what are the aims? Promote lung expansion, that is treat the primary episode, eliminate pathogenesis. Unless you do that, you will have higher recurrence and decrease recurrence. Let's see. So this is one study which compared chest tube drainage versus needle aspiration and found that there was no difference between chest tube drainage and needle aspiration, something which he also has alluded to. Another analysis where several series have compared chest drain versus surgery. Whenever you look at chest drain, you find very high recurrence rate. This was chest tube alone and patient left alone after that. Whereas when you look at VATS done per primum or as it subsequently, you find there are much lower, in the range of 2 to 3% reported with VATS as compared to chest surgery. He talked about cost. I would like you to focus on this part. If you treat the first episode with conservative management, patient goes home and comes back with recurrence later and again is having a chest tube and then is subjected to VATS. That's one procedure. So cost of one admission goes home and cost of second admission and surgery. And they have compared that with VATS done in the first procedure itself. And when the total cost was taken into consideration, the VATS was found to be more cost effective than letting the patient suffer and come back for second admission. So all these report much lower recurrence rates with VATS. So when you compare simple aspiration, catheter, and ICD insertion compared with surgery, there is no comparison. Now let's look at chemical pleurodesis. Here they compared simple aspiration and drainage and intrapleural minocycline with just simple aspiration and drainage and found the recurrence rates to be much higher in the simple aspiration group as compared to the minocycline group. And when these patients who had recurrences were operated, most of them were found to have presence of bleps and bulli, which was the cause for recurrence, and then they underwent surgery. Length of hospital stay was almost equal. Length of total hospital was equal. And post-operative pneumothorax recurrence now after surgery was 0. Again, when they looked at the presence of bleps and bulli, in both groups you found very high presence of bleps and bulli, and later on the recurrence rate was 0. So there is mention about blood patch also, but I'll skip this. This slide, he also showed that when you compare the recurrence rate with the surgical pleurodesis versus pleurodesis done medically, you find the best results are coming in the surgical group. This paper talks about, is video-assisted thoracoscopic surgery talc pleurodesis superior to talc pleurodesis done via tube thoracostomy? And it says that in reality, the lowest recurrence rates are observed when you have pleurodesis done by VATS, because you achieve much better spread of the talc there, and this again is mentioned. And here also they have mentioned, they have compared the rates of, sorry, it may not be clear here, so I'll skip this. So when you compare all these results coming about chemical pleurodesis, which are comparing chemical pleurodesis done medically to VAT surgery, again, in all these reports, surgery is proving to be superior. So what does the summary of literature say? There is no ambiguity about this fact that the lowest recurrent rates are reported with surgery. Initially, thoracotomy was resorted to, which was actually the reason why surgery was always objected to. But now, VATS is the standard of care, which has much lower morbidity, hardly any mortality reported, and much lower costs also. So always, long incisions, post-operative pain, reduced quality of life is what my friends have always been quoting. Oh, these are the problems with surgery. But friends, that is the reason why all these guidelines actually do not talk about VATS in the first episode of pneumothorax. Even if you look at these guidelines, they say indications for surgical, second ipsilateral pneumothorax, mind the word, second, first contralateral, bilateral, and first responder. So nobody actually has talked about VATS in the first episode. But the way things are moving, I'm going to prove that this actually is the way forward. So procedures to prevent the recurrence of a primary sponge should be reserved. So all these talk about VATS in the second episode. But friends, times have changed. And so have the incisions. From big incisions, we move to, so this is what we used to give our patients in the past, but this is what we give our patients now. And therefore, because of small surgical wounds, no rib spreading, no tissue trauma, similar efficacy, decreased morbidity, and much superior quality of life, ability to get back to work in max 1 week time. This is what is making VATS the standard of care today. Starting from early 90s, there have been numerous reports which actually talked about VATS as the standard of care. There was only one report which had adverse, which was in Lancet 2007, which reported a 4-fold increase in the incidence of recurrence when VATS was done as compared to thoracotomy. And the reason was this actually was taking into consideration the beginning of the first few years of VATS. But later on, when you look at all other recent guidelines, all of them say VATS is indicated at the surgery for pneumothorax. Moving further, we were not satisfied with VATS, which was using 5 or 10 millimeter scope. We now had needless scopic, where 2 to 3. So what you do, you have the chest tube already there. You can use the 10 mm chest tube incision for putting your stapler, and you put a 2 to 3 millimeter scope and another 2 to 3 millimeter instrument. So all that patient has is the same chest tube and few other. So there are a lot of reports available where the needless scopy is proving to be as effective as the VATS. And another addition is, instead of 3 ports, you combine a 2 centimeter single incision, which is called single port incision, which also. So there is now enough evidence to say that VATS is the new gold standard, with less intraoperative blood loss, less pain, less hospital stay, better cosmesis, and fewer wind complications. So ladies and gentlemen, the choice is yours. You can either leave the patient like this, by resorting to various medical methods which will have a higher rate of recurrence and unpredictable outcome, or you can make your patient happy and give him lowest recurrence rate, less post-surgery pain, and a much better quality of life by offering him surgical methods. Just last slide. We looked at our experience also. This is not yet published, so it would be taken a very lower level of evidence, but I thought I'll just share with you. In the last 6 years at Gangaram, we've had opportunity to handle 102 cases of primary and 84 cases of secondary spontaneous pneumothorax. As expected, these patients are older. Unexpectedly, I don't know why, right side is predominant in both, few bilaterals. And look at the success rates. This is VATS, blebectomy, and pleurodesis, for which we use mechanical abrasion, 2.9% recurrence rate in this group and 8.9. So friends, the issue today is not whether surgery is the standard of care for prevention of recurrence or not. No, that's not the issue. I think the issue is much beyond, and that is, in the era of small incision VATS and needless scopic methods, with such low morbidity, no mortality, and almost negligible long-term recurrences, why should VATS not be offered as first-line therapy in the very first episode of pneumothorax? Why do you want to treat that patient with observation or aspiration or chest tube? Let him recover, go home. He suffers from this fear. He cannot go out, he cannot play. They are told to rest. He keeps suffering. When will I get my second episode? When will I get? 50 to 60% of them will have a second episode, come back, and then you subject them for surgery. So I think, friends, it's time to re-look at all the guidelines, and instead of saying that the recurrence of pneumothorax, contralateral pneumothorax, bilateral pneumothorax, hemopneumothorax, or failure in the time of chest tube in the first pneumothorax being the indication for surgery, I think it's time where we should say when the patient comes with pneumothorax, that is the best time to offer him VATS. He will be able to cure the primary episode. He'll be able to have the lowest possible 1 to 2% recurrence rate in the long term and much better, superior cosmesis. So I would like to conclude by saying VATS is the most effective definitive therapy for recurrence prevention and spontaneous pneumothorax. Apart from VATS, moving further, needless scopic and single ports are now emerging as good alternatives. Side by side, improving understanding of post-op analgesia and chest drainage is being used to refine the clinical pathway still further, and advances in minimally invasive surgeries are lowering the threshold of surgical candidacy. And ladies and gentlemen, I think it's now time to go ahead with a paradigm shift and offer VATS to our patient as the first line therapy in the first episode of pneumothorax. Thank you very much.